Okay, this is a young gentleman, actually a very high-ranked police officer who we had done LASIK on many years ago, over 15 years ago. He has regression in just one of his two eyes. We had let that eye to be a -1. We did a LASIK enhancement. This is him 2 weeks later. We only corrected a -1, minus half astigmatism, and he's a +1.5. These are his epithelial maps. And we can see there's really something funny going on. I kind of gave it away with the first picture because we can see the significant epithelial ingrowth that unfortunately was not picked up by our team early on. So what do? We go in and we will try, and this is at 8 times speed. Um, you can see the photophobia of the patient. We're going to try and demarcate with the Sinskey hook the borders of the original LASIK flap. So we will relift the flap, and we're going to try and remove the epithelium. Remember, the pearl here is sometimes there's epithelial that is left behind on the back side of the flap. So we're going to dry our field, work a lot with the patient on him concentrating on the light. This is obviously very uncomfortable. He recently underwent the enhancement, and here's the epithelial ingrowth. You can see all these threads of epithelium. I'm very careful in not teasing the edge of the flap of the epithelium, because that will invite new epithelium in to heal. So I've cleared the field. There's no epithelium on the stromal bed. And now comes the tedious part, to go in with a dry Wexel and remove another little piece of epithelium that's on the underside of the flap. I'm very careful. I don't want to damage the flap. And sure enough, I will pick up a last little slice, antibiotic, rehydrate. And the question here is, would you leave the case as is? He already had epithelial ingrowth in an uneventful enhancement. So there's vigorous epithelialization, this patient, at the edge of the flap. So of course, in trying to be as preemptive for this patient, I'm using a Johnston applanator to milk out all the fluid, probably at the edges of the flap. I'm going to take the difficult decision using a drop Pred Forte to delineate the flap edges. I'm coming in carefully with a dry WEC, and I'm seeing the nice clear edges all around, but I'm still contemplating. I've discussed this with the patient. I don't like the position of the flap. I'm going to reposition, re-iron with my Johnston applanator. I'm getting better centration from the edge, and as you guessed, I'm preparing my 10-0 nylon suture to come in and suture the flap in place, not because I have stria this time, but I want to put as much as possible as a block to reoppose the flap edges and reduce the possibility of epithelial ingrowth down the line. And of course, this is a tedious process both for the surgeon and for the patient. It's a procedure that takes about 20 minutes. We're seeing this times 8. I would love to suture as fast as it looks in your screen, but I am not at that level. I'm leaving the video uncut because it is very difficult to suture these cases. Remember, the flap, this was a femto flap with the FS200 femto, is 110 microns thick, and I'm trying to get a nice bite through the residual cornea in order to stretch the flap enough and make it reattach snugly, if I can use the term, on the stromal bed and the edge. So you can see from the way I'm placing these sutures, and again, I'm using this video unedited, but fast forwarded 8 times on how we have the 4 cardinal, one being the hinge points, and then we'll complete the other 4 sutures to put a total of 8 sutures, 7 rather sutures, as the role of the 8th suture is played by the hinge of the flap, this superior hinge. We're obviously seeing the surgeon's view. Very important to be very patient here, trying not to cheese wire a suture through the flap, because then you're left with a torn part of the flap, and in this patient that has a predisposition for epithelial ingrowth, probably opening a window for further problems. We're going to go on suture number 5. and we have now good reapposition of the lower part of the flap. Again, are all knots squared, trimmed. We will bury the knots, and we're left with two last sutures. And the reason, obviously, this is relatively basic for all the anterior segment surgeons out there, and cornea surgeons for sure, but I want to reflect the technique behind the way we're suturing the flap. We're not just reopposing the flap, because this will pose a very high risk of tearing the flap, but I'm getting a good bite of the underlying stroma and the cornea stroma outside the flap. I'm on my last suture, and obviously I'm doing my best effort to have patient comfort. We dropped a few times with Alkane. This is the Parakin version that we use in Europe, here in Center, LaserVision Ambulatory Surgery Center in Athens, Greece. I'd introduce myself, John Kalopoulos, um, from Athens, Greece, in New York City, New York, clinical professor of ophthalmology at NYU Medical School, and here the surgeon that attempts to fix the problem postoperatively. Epithelial ingrowth is very well known. I used Chat GPT over the weekend, found out that the number one problem with cases post-refractive surgery is dry eye. And epithelial ingrowth is in that list, as well as undercorrection, overcorrection, and visual performance. And we have worked a lot, published a lot, using my Pred Forte drop to here again delineate the sutured now flap edges. I'm relatively happy. I'm trying to milk out any fluid underneath the flap. It looks pretty, after the procedure, you can see here with edema, the vision has dropped from 2070 to almost 2100. So this is the patient a week later. The vision has increased to 2030 minus, and I'm actually, that was the day after. This is the week later. We're at 2030 minus. I'm corrected, but obviously with some disturbance from stretching. I'll be very careful in cutting the sutures, and I will pull the edges from the peripheral part of the cornea, so not to lift the flap. This is without sutures. Vision has improved to 2025 already, about half hour after suture removal. We'll see the pentacam half hour later. It's far more regularized than we saw before, and we expect nothing but a full recovery in this patient. I hope you found this interesting. This is John Kalopoulos signing out from our center here in Athens, Greece. Thanks so much.